Now let's move on to the pathogenesis and histopathology of the brain abscess. So in this section we will stick to this pathogenesis and histopathology of the brain abscess. We will talk about what are the different stages of pathogenesis, how it develops, how it forms, and how the patient with brain abscess will present, and what are the signs of raised intracranial pressure as a result of the brain abscess. So pathogenesis and histopathology. Histo is the tissue. Histo is the word for the tissues, and pathology is the abnormality. So what are the abnormal findings in the tissues of the patient with the brain abscess? So pathogenesis and histopathology. There is pre-existing areas of ischemia, necrosis, hypoxemia in the brain. So very important point that in patients who develop brain abscess, there is already present in the brain area of ischemia, decreased supply of blood, decreased supply of oxygen, and as a result of that there is necrosis or death of the tissue, and there is decreased oxygen. So all these are the pre-existing conditions in patients who have hypoxia. In patients, who have brain abscess. Hypoxia occur as a result of the ischemia. Bacterial invasion of brain parenchyma. So as a result of all these changes which are in the brain, ischemia, necrosis, and hypoxemia, this provide a nidus for the growth of microorganism or for the invasion and multiplication of the bacteria. Abscess evolved through different stages, influenced by nature of infecting organisms. So it's important the progress of the formation of the abscess passes through different stages depending on what is the causative microorganism. Also affected by host immune competence. If the immune system is weak, then even the microorganisms which are not very pathogenic, they can cause abscess or disease process. So immunity of the patient is very, very important in the pathogenesis. Now, the stages of pathogenesis, what are different stages through this disease progress? We have early cerebritis stage, so initial infection of the cerebrum in the early phase, which is day 1 to day 3. So 1 to 3 days are the early phases of infection. Perivascular infiltration of inflammatory cells occur. So there is perivascular, around the blood vessels, infiltration of inflammatory cells occur. Surround central core of coagulative necrosis, and there is edema occur which surrounds the lesion. So in the first 3 days there is inflammatory cells invasion, and then we have central core of coagulative necrosis is present, and this is surrounded by the inflammatory cells. This then progress to the edema. Then in the late stages, which is from day 4 to 9, there is formation of the pus, enlargement of necrotic center surrounded by the inflammatory cells, macrophages, and fibroblasts. These are the stages in which the progress of abscess occur, pathogenesis of brain abscess occur. And then finally, capsule is formed of fibroblast and reticular fibers. So these are the stages from day 1 to 3, early stage. From day 4 to 9, we have late stage. Then the stages of pathogenesis, again, early capsule formation stage, day 10 to 13. So now this is the stage in which the capsule is formed surrounding the abscess. Third stage, formation of capsule better develop on cortical. Ring enhancing capsule appearance on neuroimaging studies. So different neuroimaging studies in these days, day 10 to 13, you can see the capsule formation here. Then the late capsule formation, day 14 and beyond. Now what happens, there is well-formed necrotic center surrounded by dense collagenous capsule, surrounding area of cerebral edema regressed, marked gliosis with large number of reactive astrocytes. Development of seizures as a sequel of brain abscess. So in the late stage of capsule formation, there is regression of edema which is present, and there is marked gliosis with increased number of astrocytes. And in this stage now the seizures can occur, which is as a sequel or complication of the brain abscess. Clinical presentations of the condition presents as expanding intracranial mass lesion, so it's expanding. Evolution of signs and symptoms extremely variable. Clinical triad is present, which is of headache, fever, focal neurologic deficit in less than 50% cases. So there is fever, headache, focal neurological deficit present. Depending on the site of the abscess and what part is affected, focal neurological signs are associated with that. Common symptom, headache, in more than 75% of the patient is present. Also, headache characteristic of brain abscess is the constant dull headache. Aching sensation is present. It's like a dull, constant aching pain. Either hemicranial or generalized, either on the one side or it's the generalized headache. Become progressively severe and refractory to therapy. There is fever also, which is in 50% of patients at diagnosis. Absence not exclude the diagnosis. So if fever is not present, doesn't mean that there is no brain abscess. Presenting sign is focal or generalized seizure activity in 15 to 35% of patients. Focal neurologic deficit which are present in patients is hemiparesis, loss of sensation on half of the size and difficulty in speaking. Visual field defects also develop. Part of initial presentation in more than 60% of patients, they will present with these features that alert the physician that there might be some underlying cause. Presentations, clinical presentation in this case depends on the location of the abscess. It's very important. What site is involved as a result of the abscess, nature of primary infection if present, level of intracranial pressure as a result of the abscess. Frontal lobe abscess, if the abscess develop in the frontal lobe or front, usually we have hemiparesis. Temporal lobe abscess will have dysphagia, difficulty in speaking, upper homonymous quadranopia. Cerebellar abscess leads to nystagmus and ataxia. Cerebellum is associated with balance on walking, so it can cause incoordination on walking. So, frontal lobe, hemiparesis. Temporal lobe dysphagia and homonymous quadranopia, nystagmus and ataxia. So whatever are the neurological signs, that gives the idea roughly which area will be affected by the abscess. Signs of raised intracranial pressure. We have papilledema. On ophthalmoscopy, there is papilledema, nausea and vomiting. All these are associated with increased intracranial pressure, drowsiness or confusion, dominant presentation of some abscesses, particularly those in cerebellum. Meningismus, irritation of the meninges, not present unless abscess rupture. Infection spread to subarachnoid space. So a raised intracranial pressure can cause papilledema, nausea, vomiting, drowsiness, confusion, and then it can cause, especially in abscesses which are present in the cerebellum, then if the abscess rupture, it can cause irritation of the meninges and it can also spread to subarachnoid space. So that was all about this section. Thank you for watching sqadia.com.